Hello, my name is Martin Hutchings. I'm a senior consultant at the Department of Hematology in the Phase 1 unit at Rigshospitalet in Copenhagen, Denmark, and a professor of hematology at the University of Copenhagen. I'm very grateful for the invitation to this meeting and I'm happy to share with you some of my thoughts about the management of relapsed and refractory diffuse large B-cell lymphoma, including a focus on the bispecific antibodies, which I've worked with in the last 7-8 years. These are my disclosures, some of which are relevant to the content of this talk. First, a bit of background. This is the Palmer trial, well known to all of you, published almost 30 years ago, but no longer relevant in the current era because it included only chemosensitive patients and it only included patients naive to rituximab, which made a big difference, and the promise of curing 50% with chemotherapy in second line no longer holds. We know that from several studies, including the ones shown here, the Coral study, Orchard, and the LI12 study, all attempting to find a better induction chemotherapy prior to autologous transplant, but failing to do so, and on top of that showing that in patients previously exposed to rituximab, which means 100% of patients nowadays, the chance of cure is at best 25% if the patients are late relapsers, and probably only 10 to 15% if the patients are primary refractory or relapse within 1 year of completion of first-line chemotherapy. So there is a great unmet need, not only in second, but also in later lines treatment of this disease. But in recent years, we've seen quite a few significant steps forward. I'll mention a few of them. This is the study, a randomized phase 2 study of polatuzumab vedotin plus rituximab bendamustine versus standard rituximab bendamustine, which is arguably not the greatest standard arm in this setting, but still something that we occasionally use in elderly and frail patients and patients exempt of other options. Now, this study, as you can see, showed a really meaningful difference between the treatment arms, both when looking at progression-free survival, which I show here, in favor of the polatuzumab containing arm, but actually also a statistically significant benefit when looking at overall survival. The patient group treated here was not the worst prognosis, but still 40% complete response rate, with some of these being quite durable, is not a bad thing in this difficult to treat situation. Similar things could be said about the L-MINE study. That was not a randomized study. It was a single-arm phase 2 study of the anti-CD19 naked antibody tafasitamab, which in combination with lenalidomide also led to complete responses in 40% of patients. And as you can see in the graph showing progression-free survival according to depth of response, the complete responders actually lasted quite long in many cases. And of course, in this case, lenalidomide was given for 12 months, but tafasitamab was given until progression. So, of course, we cannot say that this has a curative potential, but still really deep and, in many cases, lasting responses. Not quite so high complete response rate was shown in the phase 2 study of loncastuximab tesirine, which is an ADC targeting CD19 and using the tesirine payload. 48% of heavily pretreated and high-risk patients responded, including 24% with complete responses. And as you can see in the progression-free survival curves on the right and the duration of response curves on the left, the complete responses were in many cases quite meaningful and highly durable. And in this study, treatment was given up to a maximum of 12 months. So perhaps a small curative potential among the patients reaching a complete response. But the real revolution in the last 5 years has been the introduction of the CAR-Ts, all targeting CD19, at least the hitherto approved ones, and showing more or less the same results. I'm showing you here data from the ZUMA-1 study of axi-cel in relapsed refractory large B-cell lymphoma. Patients going into this study had at least 2 prior lines of therapy, and 2/3 of the patients had been refractory to the most recent therapy. Yet responses were seen in over 80% of patients, including 58% with complete responses, and you can see progression-free survival at more than 2 years of follow-up was around 39%, and in an indirect comparison with historical data from the SCHOLAR-1 study, where patients were treated with conventional chemotherapy, you can see that at least in this indirect comparison, there is a massive benefit in favor of the new method of treatment. Similar results that I don't show were shown in the Transcend study of Lysocell in the same indication, and the Juliet study of Tisacell also in the same indication. And these 3 CD19 CAR-Ts have been approved in most recent regions globally and reimbursed in some for the treatment of large B-cell lymphomas with 2 or more prior lines of treatment. And with such good results, it was only logical to try and introduce CAR-Ts also in second line, because as I just showed you, the outcomes for conventional chemotherapy-based treatment are in most cases quite dismal. So this is the ZUMA-7 study, a randomized study where the experimental arm was axi-cell CAR-T and the standard arm was chemotherapy induction followed by high-dose chemotherapy with autologous stem cell support. You can see that the primary analysis was grossly in favor of the experimental CAR-T arm, with event-free survival at 2 years of over 40% in patients treated with CAR-T and the expected 16% among patients treated in the chemotherapy-based standard arm. So this study, as well as the Transform study, a similar phase 3 study of Lysocell versus chemotherapy standard of care, have led to the approval of these 2 CAR-Ts also in second-line treatment of patients with either primary refractory disease or relapse within 12 months of completion of first-line chemotherapy, because these were the patients who could be included in the phase 3 studies. Later, we've seen the introduction of the bispecific antibodies. The clinical work with these antibodies have been going on for a while now, but more recently we've seen data coming out of the pivotal phase 2 studies of some of these CD3, CD20 bispecific antibodies. This table is just an overview of the characteristics of the patients going into these phase 2 studies, and I'll point your attention particularly to the studies of glofitamab and epcoritamab, which are the approved agents in most regions, and I'll show you how strikingly similar and how quite high risk these groups of patients were. Just over 150 patients in both studies, median range line of therapy is 3, around 60% with primary refractory disease, just around 85% of patients with refractoriness to the most recent treatment line, so significantly more than in, for example, the ZUMA-7 study, and around 1/3 of patients with exposure to prior CAR-T and failure, obviously, of that CAR-T. But first, the results from the phase 2 study of mosunetuzumab, which has been approved for treatment of follicular lymphoma and also tested in large B-cell lymphomas. As you can see, responses were seen in 42% of patients, including 24% with complete responses. And even though 10 years ago these response rates would have been very promising in large B-cell lymphoma relapsed refractory disease, this has not been sufficient to continue the development of mosunetuzumab in the aggressive B-cell lymphomas. Odronextamab is another CD3, CD20 bispecific antibody which has continued development in this space. It has had a rough ride through phase 1 because it had quite a lot of toxicity with high frequency and grades of cytokine release syndrome, also ICANS, but with a very complicated step-up regimen over 5 different dose ranges where the first 3 doses have to be given in split doses over 2 consecutive days. It has been successfully been achieved that the CRS rates have come under control, and we now see the readout both of safety and efficacy, showing a 49% overall response rate, including 31% with complete responses. Odronextamab, so far in the development and also in the phase 2 studies from which I show data here, has been given until progression, so the duration of complete response curve on the right is perhaps not so encouraging, since you see no development of a plateau despite treatment being given until progression. So I'm jumping to the antibodies with which I have experience, that's glofitamab and epcoritamab. And just to give you a taste of the activity of these drugs, I'm showing you one of the first patients of mine with a meaningful clinical response to glofitamab. So he was treated in the phase 1 study in the relatively early days of the phase 1 study, where we still gave patients flat doses, no step-up dosing, which has later been introduced into all the different bispecific antibodies, and this is to reduce the risk of high-grade cytokine release syndrome. So at this point, this guy was 42-year-old. He had a chemorefractory, relapsed refractory large B-cell lymphoma. And after the first dose of glofitamab, which I believe was in the low milligram ranges, so approximately tenfold less than what is now the recommended dose, he developed a mild cytokine release syndrome, but also severe tumor pain in his tumor sites, and also a Horner syndrome developed over the first 12 hours of treatment, which is really interesting. You could see a tumor flare from his tumor compressing the sympathicus during the night of following the first infusion. He was, as you can see, after 2 cycles in a very deep partial response, and the only remaining bit of his disease at the end of his 8 cycles of treatment was a little bit of PIT-positive disease in his left supraclavicular region, which we irradiated, and at this point, 5 years after the end of treatment, he's still in a complete response, despite receiving, like I said, a dose which is about 10% of what we now will give patients with glofitamab. So I jumped to the phase 2 study of glofitamab, which has led to the approval of that drug both in the US, in Europe, and in many other regions in the world. This study, like I showed you before, including just over 150 patients, and they were, as I already described, very high risk, difficult to treat, and highly refractory. You can see on the left the key inclusion criteria, at least 2 prior lines of treatment, including an anti-CD20 antibody and an anthracycline. They needed reasonable performance status, reasonable organ function, and they would be treated not only with step-up dosing, 3 consecutive increasing doses during cycle 1, but also, like all of the patients treated with glofitamab, a pre-treatment with obinutuzumab, so naked anti-CD20 antibody, 1 week before the first dose of glofitamab, in order to deplete peripheral B cells and reduce tumor burden in order to avoid high-grade cytokine release syndrome. You can see here a diagram of the antibody. It doesn't look like most IgG-based antibodies in that it has 2 epitopes for CD20 and 1 for CD3, so it's a 2-to-1 format, unlike all the other CD3-CD20 antibodies, which I will describe. In this phase 2 study, we had already learned a lot about toxicity and how to avoid it. So cytokine release syndrome, which is the dominant acute toxicity of the bispecifics, was really quite controllable, with CRS seen overall in just under 2/3 of patients, but the vast majority of cases of grade 1 and very few cases of grade 3 to 4 cytokine release syndrome, which is where it gets really tricky to treat. You can see that almost exclusively it's during cycle 1 and on cycle 2, day 1, that we see CRS. This is a first pass phenomenon, and after the first 3 to 4 weeks of treatment, we practically do not see it anymore. At that point, the side effect profile is taken over by other things, particularly cytopenias and the occasional infections that we have to struggle with. Responses in this phase 2 study were seen in 52% of patients, including 40% with complete responses. And you can see that despite glofitamab being given for a fixed duration of time, maximum 12 cycles, equaling 8.3 months, we still see durability. We see that among patients reaching a complete response, approximately half still maintain that complete response 2 years after the end of treatment, which is really quite impressive regarding how sick and refractory these patients were going into the study. These are charts showing progression-free and overall survival for patients according to depth of response. The dark blue curves represent patients reaching complete responses, and I think it's a testament to the clinical meaningfulness of these responses when you look at the overall survival curves, how significantly different they are from the overall survival of patients reaching only partial a response or no response, because remember, these patients would expectedly be treated in places where patients would have access to excellent standard therapy and also other experimental options. So these responses are not only deep and durable, they are also clinically really meaningful in my eyes. This is a landmark analysis of progression-free and overall survival, where survival is counted from the end of treatment. And this is really quite useful when we sit in front of our patients, because some patients I treat with epcoritamab, where they are treated until progression, others with glofitamab, And sometimes the glofitamab treated patients wonder, why do I stop treatment when the other patients get to go on until progression, and vice versa? And then you can show them these landmark analyses showing that when you stop treatment, if you're in complete response, which is the case for about 40% of patients, your chance of being alive and progression-free still after 2 years is about 50%, which is really quite encouraging. This is another patient treated with glofitamab. Now, this patient was treated a little bit later, more elderly than the other patient, 69 years, treated for a transformed follicular lymphoma, given 3 prior lines of treatment, to which he had been refractory to the 2 most recent lines. He was treated in late 2018 and 2019 with glofitamab, and at that point, treatment was given at what is now the recommended phase 2 dose. He had a mild CRS of grade 1, despite having a very high tumor burden. As you can see, he went into a deep partial response after 2 cycles, transformed into a complete response after 5 cycles, and at the end of the 12 cycles of treatment in June of 2019, he was still in a CR, which lasted for more than 2 years, and it lasted until he unfortunately died from a chemotherapy-related myelodysplastic syndrome, which transformed into acute leukemia a couple of years later. Now moving on to epcoritamab, another CD3/CD20 bispecific antibody, also studied in a recently published phase 2 study. Like I showed you, a very sick population also going into this study, and also manageable safety. You can see here that, again, just over half of the patients getting to some kind of cytokine release syndrome. But again, like in the case of glofitamab, the vast majority of patients with CRS of grade 1 or 2, which is highly manageable and very rarely beyond grade 2. Unlike glofitamab, where we see most cases of CRS after the priming dose, which is in the milligram range, after treatment with epcoritamab, most cases of CRS are seen 2 weeks into treatment, which is when the first full dose of epcoritamab is given, and that's probably because the priming and intermediate doses of epcoritamab are in the microgram range. So they probably serve more as tools for B-cell depletion, like the obinutuzumab pretreatment, than as actual tumor reduction. So the first real effect that we see after epcoritamab is after the first 2 weeks. But the effect is good. We see responses in this phase 2 study in 63% of patients, including 39% with complete responses, so more or less like glofitamab. The durability also looks a little bit similar, maybe a little bit shorter than glofitamab. The median duration of complete response is around 19-20 months versus 26 months for glofitamab, but also the comparison is a little bit tricky because, like I've already said, epcoritamab is given until progression, so it's a little bit difficult to compare the durability, and certainly difficult to state anything about curative potential when you treat until progression, whereas there is a strong hint, in my eyes at least, that glofitamab cures some of our patients even as a single agent. I'm just showing you quickly that there are new kids on the block. This is a drug called TNB-486, now AZD486, because it's been purchased by AstraZeneca. We have early results from the phase 1 study of this compound, also in different difficult to treat B-cell non-Hodgkin lymphoma populations, and you can see that even though these are really quite preliminary data, it's impressive to see response rates of 75%, including 50% complete responses in patients with relapsed refractory diffuse large B-cell lymphoma, but there are large phase 2 expansion cohorts ongoing where patients are treated with this drug, both in diffuse large B-cell lymphoma and follicular lymphoma, and it'll be interesting to see updated results from this study. Now moving on to perhaps the most interesting part of my message today, which is the combination study, because what is so brilliant about the bispecifics is not only their unique mechanisms of action and very distinct way that they work, and also very distinct side effect profiles, which means that not only can they be used effectively as single agents, they are also very easy to combine with almost any other antineoplastic agent that we use in the lymphoma space. And we can basically just let ourselves be limited by imagination and fantasy, because they can be combined with chemotherapy, might not support the mechanism of action, which is based on the T-cell activity, but still it can be additive, as we have already seen in many cases. We can combine them with more novel agents, ADCs, with CELMoDs, which have some T-cell modulatory function and also anti-lymphoma effect in themselves. We can combine them with co-stimulatory molecules. We know from the development of the CAR-Ts that they did not work particularly well until co-stimulatory signals were inserted into the CAR-T molecules, and maybe we should do the same thing with the bispecifics, adding CD28, 4-1BB, what have you. We could also combine with small molecules, tyrosine kinase inhibitors, particularly in the space of CLL and mantle cell lymphoma. It would be very logical to combine with the BTK inhibitors, for example. So let's just go for a few examples. I promise to not show you everything that's going on in these clinical development plans. This is the very complicated development plan for the ongoing studies of glofitamab, and the even more complicated development plan for epcoritamab. So of course I've had to choose a few ones of my favorites, and this is one. So this is a study of glofitamab combined with polatuzumab vedotin in relapsed refractory large B-cell lymphomas, including an enriched population of high-grade B-cell lymphomas, where we have early in the course of this study found surprisingly and encouragingly high activity. You can see that epcoritamab is given in the fashion I already showed you, so a step-up dosing. We start with obinutuzumab on the first day of treatment, but as something new here, we insert polatuzumab vedotin on the second day, so in the week prior to the first dose of glofitamab, and then for the first 6 cycles, polatuzumab is given alongside with glofitamab, and then for the next 6 cycles, glofitamab is given on its own. Inclusion into this study was for large B-cell lymphoma patients. Performance status could be up to 2. 1 prior line of therapy was enough if the patients were truly refractory and without meaningful chemotherapy-based standard options. So look at the results here. It looks as though, even though there's no biologically meaningful synergy between these two compounds, we still see very encouraging additive efficacy, with responses seen in all patients of 80%, including 60% with complete responses. And I think it's interesting to see that in the relatively high number of patients with high-grade B-cell lymphomas, still responses in 73%, including complete responses in 57%. And I will direct your attention to the upcoming ASH meeting, where we are giving updated, and I can promise you even more encouraging results with much more patients treated from this study. Another favorite of mine is the study where we combine glofitamab with the co-stimulatory bispecific molecule targeting CD19 and 4-1BB. It's called Inglumafusp alpha. I promise you will hear more about this molecule in due time. It's combined with glofitamab in a slightly different way than polatuzumab. We give the standard cycle 1 obinutuzumab pre-treatment, then step-up dosing of glofitamab, and then we add the co-stimulatory signal in cycle 2 and give it for the full 12 cycles along with glofitamab. This is based on very strong preclinical data showing, at least in the mouse models, very strong synergy between glofitamab, which is where you see the tumor control rate depicted by the red curve, and Inglumafusp alpha, where you can see the tumor control rate of the combination depicted by the purple curve. So with these encouraging preclinical data, it was a joy to start treatment with this drug approximately 5 years ago, first in combination with obinutuzumab, and later, as I show you here, in combination with glofitamab. We are also at this year's ASH privileged to show updated results, which are really quite encouraging. Here I can only show you what we have been able to present so far, the most recent data presented in the summer meetings of this year by Frank Morschhauser, and you can see that it's hard to compare indirectly, but complete response rates of over 50%, irrespective of number of prior treatment lines, irrespective of prior risk factors, and almost 50% complete response rates even in patients with prior exposure to and failure of CAR T. And we believe this is because with the 4-1BB co-stimulatory signal, as we show in these pharmacodynamic biomarker studies, we revert the expected fatigue of the T cells occurring during and late during and after completion of treatment with glofitamab, thus not only boosting the depth of response, but particularly the durability of the effect. The same idea was behind the phase 1b study of the combination of glofitamab and another bispecific co-stimulatory molecule, in this case targeting CD19 on the B cells and CD28. And this has actually shown very promising both toxicity signal and preliminary efficacy, but this program has been discontinued as the sponsor and us investigators focus on the development of Engluma Fosp alpha together with glofitamab. Earlier this year, we saw the much awaited presentation of the randomized STARGLO study. So STARGLO was a randomized phase 3 study with a 2-to-1 randomization between the experimental arm, glofitamab GEMOX, and the standard arm, rituximab GEMOX, in relapsed refractory large B-cell lymphomas with one or more prior lines of treatment, but again, patients with only one prior line of treatment had to be transplant ineligible. So really a study which included patients very representative of many of the patients that we see in our daily clinics. This study was powered to have overall survival as a primary endpoint. Quite a bold move, but indeed a positive study, as you can see on the left. Overall survival significantly better for the glofitamab GEMOX arm, and also progression-free survival significantly better for the glofitamab GEMOX arm than for the standard rituximab GEMOX arm. So really a useful combination for patients with relapsed refractory large B-cell lymphomas. And you can see the overall and progression-free survival plateauing at around 40% after 2 years of follow-up. And you can ask yourself, is this any better than the CAR Ts or perhaps the bispecifics alone? Well, it's certainly not any worse. So I think this combination is absolutely a valuable contribution to our armamentarium and certainly comparable with the approved CAR Ts. It's quite interesting to see an overall survival benefit so clearly statistically significant, despite the fact that this drug, glofitamab, is heavily B-cell depleting, and the study was carried out during the height of the COVID pandemic. And I'm showing you this because it's really, really important for the understanding of the results. In the R-GEMOX arm, there were a lot of COVID, but no fatal cases of COVID, whereas in the glofit GEMOX arm, there were also quite a lot of cases of COVID, but 7 fatal cases. So despite a 7-to-1 score in COVID-related deaths, showing the potency of the B-cell depletion and the desire and need for us to be really careful with vaccination and monitoring and treatment of these patients, you still have a very clear benefit still when looking at a primary endpoint, which was overall survival. Perhaps a less interesting phase 1b study was the combination with R-CHOP, also with polar R-CHP. This was not to demonstrate any added efficacy because that's difficult when the endpoint is response rates, but the primary endpoint for this combination study was, of course, safety, and it was shown that glofitamab can safely be combined with chemotherapy, even first-line style chemotherapy. You can see that cytokine release syndrome was actually quite rare. And why was that? Well, I guess it was because glofitamab was only introduced in cycle 2. At that point, patients have usually responded quite well. Most of the tumor burden has been reduced. And that is the explanation for why CRS was seen very rarely and only of low grade in this study, unlike the similar combination of R-CHOP and epcoritamab, which I'm not showing you here, where cytokine release syndrome was seen in approximately 45% of patients, and where epcoritamab was introduced in cycle 1 alongside with the R-CHOP. And these studies have led to the ongoing important phase 3 studies of the bispecifics. First of all, the EPCOR DLBCL-1 study, which is a phase 3 study of epcoritamab as a single agent versus R-Benda or R-GemOx as per investigator's choice in patients with relapsed refractory large B-cell lymphoma, but also importantly the DLBCL-2 study, phase 3 study of R-CHOP plus minus epcoritamab in newly diagnosed diffuse large B-cell lymphoma with an IPI of 2 to 5, so an attempt to challenge the R-CHOP standard of care. And similarly, the SKYGLOW study, which is a phase 3 study of polatuzumab R-CHIP, so another standard of care in this space, plus minus glofitamab in the same group of patients with large B-cell lymphomas of an IPI of 2 to 5 and newly diagnosed, previously untreated. The DLBCL-2 study has completed accrual. I think the SKYGLOW will complete accrual very soon, and it'll be super interesting in a couple of years from now to access the readout of these data. So towards the end of my talk, I just have a few things, practical things that I would like to address. Because of the many years of experience that I have with these antibodies, I think it's nice to have a few tips that are not always available in the publications or in the prescribing labels. So one thing that is often being discussed is what is the optimal sequencing of CAR-T and bispecifics in the large B-cell lymphomas? And the honest answer, of course, is that we don't know. I think most colleagues, and that would include myself, would probably lean toward using CAR-Ts first if there is access, and that is because we have longer follow-up, because the studies both in third line and later and in second line have been performed prior to the studies of the bispecifics, so we have a more solid long-term follow-up, and also for that reason a more solid promise of cure in a majority in a proportion of the patients. I'll get back to this. Also, which criteria should be taken into consideration when we choose patients for bispecific antibody treatment and when we use a bispecific antibody for a patient? I'll try and give a few lists of things that I think is important to be concerned and conscious about. Then a lot of patients, particularly in the follicular lymphoma, but also occasionally in the large cell lymphoma space, think about prior bendamustine, because bendamustine is not good for T cells. That goes for cyclophosphamide as well. So should we be careful with bendamustine in patients who might benefit later on from a CAR-T or from bispecifics, which are of course dependent on the functionality of the T cells? And finally, a little bit about toxicity and the need for infection prophylaxis and vaccinations, both in CAR-T cell treated patients and patients going into treatment with bispecifics. So about sequencing. I've already shown you data from the phase 2 study of the bispecifics, and without going into detail, I also showed in the slides data supporting that the efficacy in terms of overall and complete response seems to be more or less the same in the overall population, both in the study of glofitamab and of epcoritamab, regardless of prior exposure to CAR-Ts. And this, of course, would support, again, giving CAR-T prior to bispecifics. We have not until recently known whether the opposite is also true, whether CAR-Ts work as well in patients previously exposed to bispecific antibodies. But we've actually recently seen the answer to that question. It comes from retrospective data of the French DISCARD database, which is a big database of CAR-T treated patients. And what the authors showed was that both when looking at overall survival and progression-free survival, the outcomes of CAR-Ts seem to be the same in a group of patients previously failing bispecific antibody therapy. You can see the same progression-free survival plateau of around 40% that we have become used to seeing when looking at CAR-T studies. What about the characteristics of the patients? What should we be looking at when we choose and select both bispecifics for patients and patients for bispecific antibodies? I think it's very important to have the target. Right now, we only have access to CD20 targeting bispecifics, but that will change very soon. And there is no doubt that it only works if the target is expressed. We have tried multiple times to treat patients with CD3 CD3/CD20 bispecifics in patients with no or very weak expression of CD20, and generally it is not a success. We need a reasonable organ function, and I would say that the CAR-T and the bispecifics more or less take the same cardiopulmonary function in order to support pressors and oxygenation therapy in case of severe cytokine release syndrome. We need to be thoughtful about risk factors for cytokine release syndrome, tumor volume, tumor burden, leukemic disease, extranodal disease, particularly bone marrow infiltration, and also tumor type. Mantle cell lymphoma carries a higher risk, for example, of CRS than diffuse large B-cell lymphoma. Risk factors for tumor flare should be assessed, can be coexisting and even confused sometimes with cytokine release syndrome. And I can only say that even though the vast majority of patients can be treated completely safely in an outpatient setting, in elderly, frail, or high-risk patients still consider hospitalization, and also in patients living alone and or far from the hospital. What about bendamustine? Gloria Iacoboni from Barcelona presented data on CAR-Ts showing that prior bendamustine is quite reductive for the function of the CAR-T. So recent bendamustine therapy is really not good for the chance of responding well to a CAR-T. Is that also the case when you give bispecific antibodies? Same Gloria Iacoboni recently gave us the answer to that question too. No, it's not. Why? Well, maybe because when giving bispecific antibodies, you potentially bring into use all the T cells that are in the body, whereas the CAR-T, of course, is only a small fraction, which is apheresed and then developed in vitro before being given back to the patient as the CAR-T cell infusion. That is, of course, speculation, but the data show that bispecifics work equally well in patients with or without prior exposure to bendamustine. Now, I told you a little bit before about cytokine release syndrome, and I repeat that this is without a doubt the dominant acute side effect of the bispecific antibodies. But after a while, after a month or 2 or 3, the dominant side effects are the cytopenias, low immunoglobulin levels leading to a relatively high risk of viral infections, and some, but quite modest, risk of bacterial infections. Need for transfusion, very rare. Need for growth factors, quite common when it comes to GCSF, very rarely EPO or TPO. Our advice on replenishing immunoglobulins is to, or at least my advice, is to strongly consider replenishment in cases of levels lower than 4 grams per deciliter, and in cases of repeated infections and levels below 6 grams per deciliter, I will also strongly encourage replenishing the patients with immunoglobulins. Also, be quite liberal with prophylactic antibiotics. We give all our patients Bactrim. We also give all our patients anti-herpes prophylaxis with typically valacyclovir, and also be quite liberal, particularly in patients with long-term neutropenia, with the antibacterial prophylaxis. I can be typically a quinolone for 1 to 2 weeks during periods of neutropenia can be recommended. With those steps, we have actually been able to reduce serious infections in the vast majority of our patients, and during peaks of COVID, we've also been quite liberal with the use of remdesivir. What about vaccination? Well, all inactivated vaccines are considered safe, both in patients undergoing bispecific antibody therapy and in patients recently completing that therapy. So only live vaccine should be avoided during the induction phase of this treatment. Despite profound lymphopenia, despite the complete depletion of B cells and even some depletion of plasma cells, we still have shown in the Danish study that COVID mortality was almost zero because our population had a vaccination coverage of over 99% in the B-cell lymphoma population. And this is in opposition to less well-vaccinated populations, as I, for example, showed you when showing the data from the STARGLOW study, where particularly patients from North America were not so well vaccinated, and that probably was the reason for the high rate of grade 5 COVID cases. So in summary, I hope I have convinced you that the future is a little bit brighter than it was 10 years ago for patients with relapsed refractory B-cell lymphomas. I showed you examples of a number of novel agents that have been introduced, not least the CAR-Ts, leading to the development of the bispecific antibodies showing around 40% complete response rates in phase 2 studies of both glofitamab and epcoritamab in relapsed refractory large B-cell lymphomas with 2 prior lines of treatment and high-risk features, including high levels of refractoriness. So these complete responses seem durable, both for epcoritamab, perhaps even more so for glofitamab. And in the case of glofitamab, I think it's fair and unbiased to state that there is a curative potential, because we see that more than half of patients responding completely to glofitamab are still in CR 2 years after the end of treatment, because, as I've stressed, this is a treatment which is given not until progression, but for a fixed duration of time. The toxicity to the bispecifics is dominated by cytokine release syndrome, which is typically mild and transient and less severe than seen after the treatment with the most potent CAR-Ts, which are axi-cel and lisa-cel. We rarely see cytokine release syndrome more than 1 month into treatment, and at that point, toxicity is dominated by the cytopenias, particularly lymphopenia, but also to some extent thrombocytopenia and neutropenia. For that reason, we need to vaccinate our patients, we need to give prophylactic antibiotics, and we need to monitor them for low IgG levels and replenish when relevant. I showed you recent data showing superiority both for overall survival, which was the primary endpoint, and also progression-free survival of glofitamab GEMOX over R-GEMOX in the STARGLOW study, which is another important piece in the puzzle showing the value of the bispecific antibodies, and particularly glofitamab, in the treatment both in second and later line of relapsed refractory large B-cell lymphoma. And now we are waiting eagerly for the outcome of the first-line studies that I showed you, and perhaps in the future also a randomized study of a bispecific antibody. I would love for that to be glofitamab in combination with, for example, with polatuzumab vedotin and/or englumafosp alpha in second-line treatment or third-line treatment, directly compared against a CAR-T. Let's